Today, a structured clinical comparison of TMS and esketamine, what they are, how they work, and when to choose which. When antidepressant monotherapy isn't enough, clinicians need a next-step framework. Treatment-resistant depression, defined as inadequate response to 2 or more adequate antidepressant trials, affects roughly 1 in 3 patients with major depressive disorder. At this point, somatic interventions come into play. 2 of the most evidence-supported options are transcranial magnetic stimulation, called TMS, and intranasal esketamine, marketed as Spravato. Both have FDA clearance, robust trial data, and distinct clinical profiles. This episode builds a practical decision framework for both treatments. TMS uses electromagnetic induction. A coil placed against the scalp generates a rapidly changing magnetic field that passes through the skull entirely painlessly and induces an electrical current in the underlying cortical tissue. That current depolarizes neurons, primarily in the dorsolateral prefrontal cortex, the DLPFC. The downstream effect is modulation of distributed brain networks involved in mood regulation. Unlike electroconvulsive therapy, TMS does not induce seizures. It does not require anesthesia, and it has no systemic effects because the magnetic field acts locally on cortical circuits. The most established protocol is high-frequency repetitive TMS, 10 Hz pulses delivered over the left dorsolateral prefrontal cortex. Standard courses run 5 sessions per week for 4 to 6 weeks, roughly 20 to 30 total sessions. Each session lasts about 30 to 60 minutes, and patients remain fully conscious and alert throughout. 2 notable variants are worth knowing. Theta burst stimulation, known as ITBS, delivers clusters of 3 pulses at 50 Hz in short bursts, allowing similar efficacy in a shorter session. Deep TMS uses an H-call designed to reach deeper brain structures, also FDA-cleared for depression. Here's what the evidence shows. Across 29 randomized controlled trials, high-frequency left TMS achieved a response rate of about 29% versus just 10% for sham, giving a number needed to treat of 6. Remission followed about 19% of active treated patients compared to 5% on sham, with a number needed to treat of 8. More recent trials, including the large 300-patient 3D trial, showed response rates around 45 to 47% for both standard 10 Hz TMS and theta burst stimulation, with remission rates around 30%. The take-home: TMS works, the effect is clinically meaningful, and theta burst appears non-inferior to standard high-frequency delivery. The safety profile of TMS is favorable. The most common side effect is scalp discomfort or headache, reported in roughly 60 to 65% of patients across the landmark trials, generally mild and self-limiting. Seizures are rare but possible, occurring in approximately 3 per 100,000 treatments with standard figure-of-8 coils, and roughly 1 per 30,000 with deep TMS using the H-call. Importantly, TMS carries no sedation, no systemic side effects, no drug interactions, and no abuse potential. There is no required monitoring after a session. Patients remain fully functional and can drive themselves home and resume normal activities immediately. The main logistical burden is the frequency. 5 visits per week for 4 to 6 weeks requires substantial patient commitment. Esketamine is the S enantiomer of ketamine, a non-competitive antagonist at the NMDA receptor. Unlike most antidepressants that target monoamine systems, ketamine's primary mechanism is glutamate modulation. By blocking NMDA receptors, it disinhibits glutamate release, producing a surge in glutamatergic activity that drives synaptogenesis, the formation of new synaptic connections, and strengthens prefrontal cortical networks. This mechanism works far more rapidly than monoamine targeting drugs. Some patients report symptom improvement within hours of the first dose. The rapid onset is one of esketamine's most distinctive features. This is critical clinical context that must inform every esketamine prescription. Spravato carries a boxed warning for sedation, dissociation, respiratory depression, and abuse potential. Because of these risks, esketamine is only available through the Spravato REMS program, a mandatory FDA risk evaluation and mitigation strategy. Certified clinics must monitor patients for a minimum of 2 hours after each dose with pulse oximetry. Patients must be enrolled in REMS, have a companion to safely transport them home, and must not drive until the day after dosing. Blood pressure must be checked at baseline, and periodically, transient elevations occur during the dissociative period. This is not a take-home prescription. It is an in-clinic therapy with structured monitoring every single session. Efficacy data from the Phase 3 program shows meaningful benefit. In the Transform 2 trial, patients receiving esketamine nasal spray plus an oral antidepressant showed a significantly greater reduction in MADRS scores by day 28 compared to antidepressant plus placebo, with clinically meaningful improvement apparent as early as day 1. The landmark Sustain 1 maintenance trial showed that continuing esketamine reduced relapse risk by 51% in patients who had achieved remission, giving a number needed to prevent relapse of 6. More recently, the ESCAPE TRD head-to-head trial compared esketamine directly against quetiapine extended release, showing remission rates of 27% versus 18% at week 8, a statistically significant advantage for esketamine. The rapid onset advantage is real. Esketamine can show significant effects within 24 to 48 hours. The side effect profile of esketamine centers on its dissociative properties. Dissociation occurs in roughly 20 to 25% of patients, described as distortion of time, space, and body perception, and usually resolves within 60 to 90 minutes post-dose. Nausea affects about 25%. Dizziness and headache each occur in roughly 20%. Transient blood pressure elevation is common during the dosing window. Clinicians check baseline and monitor throughout. Critically, there is abuse potential. This is a Schedule III-controlled substance under the ketamine isomer classification. The logistics are also demanding: twice-weekly office visits during induction, weeks 1 through 4, then weekly or bi-weekly maintenance. Each visit, including observation time, runs approximately 2 to 3 hours. Here is how the two treatments stack up side by side. Mechanistically, TMS uses electromagnetic induction while esketamine targets the NMDA glutamate system, fundamentally different modalities. Invasiveness: TMS is non-invasive and external. Esketamine is intranasal and requires clinical infrastructure. Onset: TMS takes 2 to 6 weeks. Esketamine works within hours to days. Treatment frequency: TMS 5 times weekly for 4 to 6 weeks. Esketamine twice weekly induction, then weekly maintenance. System safety: TMS has minimal systemic effects. Esketamine requires monitoring for dissociation and BP. Abuse potential: none for TMS, significant for esketamine. Monitoring burden: TMS requires nothing post-session. Esketamine requires 2-hour observed monitoring, companion, and no driving until the following day. Consider 2 clinical scenarios where esketamine may be preferred. First, a patient with active suicidal ideation requiring rapid intervention, or a patient in severe depressive crisis needing the fastest possible response. In this context, esketamine's onset within hours to days is a critical advantage. The clinical evidence from the Transform trials shows MADRS improvement beginning at day 1. Second, a patient with substance use disorder history. Here the picture is more nuanced. While TMS has no abuse potential and may be preferred on that basis, esketamine is not absolutely contraindicated in SUD, but it does require careful assessment and shared decision-making given the boxed warning and Schedule III status. Now consider the opposite profile, a patient who wants to avoid sedation, procedures, or any invasiveness. Here TMS has a meaningful advantage. It requires no medication, no sedation, no blood pressure monitoring, no REMS enrollment, and no companion for transportation. The patient can come in during a lunch break and leave fully functional. Substance use history, particularly history of ketamine abuse or active misuse, also tilts the decision toward TMS. And for patients who have previously failed or poorly tolerated ECT, TMS offers a non-invasive alternative without anesthesia, memory effects, or seizure risk. Real-world access often shapes which treatment is actually available. TMS requires a specialized clinic with a TMS device. These are not as widely distributed as general psychiatric offices. Patients in rural or underserved areas may not have convenient access. Esketamine requires a REMS-certified clinic, which also limits distribution, though REMS-certified sites are increasingly available. From a logistical standpoint, a patient who cannot commit to 5 visits per week for 6 weeks may find esketamine's twice-weekly induction more feasible. Insurance prior authorization is required for both and can be substantial. TMS typically requires documentation of adequate antidepressant trials. Esketamine requires TRD diagnosis and failure of at least 2 antidepressants. Cost is significant for both. TMS runs roughly $400 to $600 per session, totaling $12,000 to $18,000 for a full course. Esketamine runs roughly $1,000 to $1,500 per session, depending on dosing. Here is a consolidated decision heuristic for clinical trainees. If rapid response is the priority, active suicidality, severe crisis, lean toward esketamine. If non-invasive delivery is preferred, if there is substance use history, or if the patient cannot make frequent visits, lean toward TMS. For patients with TRD who have failed ECT, both are reasonable next steps. The choice depends on the factors we have outlined. In practice, many clinicians use a shared decision-making framework. Present both options, discuss the logistics and monitoring differences, and align the choice with patient preferences, access, and clinical urgency. Neither treatment is universally superior. The right choice depends on the individual patient in front of you. A few final points to retain. TMS and esketamine are both FDA-cleared, evidence-supported treatments for treatment-resistant depression. They are not experimental. TMS uses electromagnetic induction of cortical currents. Esketamine uses NMDA antagonism to drive a glutamatergic response. TMS onset is gradual over 2 to 6 weeks. Esketamine acts within hours to days. TMS requires 20 to 30 sessions over 4 to 6 weeks with no post-session restrictions. Esketamine requires REMS-certified infrastructure, 2-hour observed monitoring, a companion, and no driving until the next day. Both reduce relapse risk in responders. The clinical decision hinges on onset urgency, invasiveness tolerance, abuse risk, access, and patient preference. Before you go, comment with the factor you think most often decides between TMS and esketamine in real clinical practice. Rapid onset, monitoring burden, substance use history, access, or patient preference. Questions about what you learned today, or topics you'd like to see covered in future episodes. Talk with your doctor or prescriber. This content is for educational purposes only and does not constitute medical advice. Questions about today's content or topics you'd like to see covered in future episodes. Drop them in the comments below. And if you found this clinically useful, hit subscribe. More psychopharmacology breakdowns are coming. This video is for educational purposes only and is not a substitute for clinical judgment.